The sacroiliac joint is where your spine connects to your pelvis, and it's really a fairly non-moving joint. It's down here where you have that dimple on either side of your, right above your backside. And it's a stiff connection between the tailbone or sacrum and the iliac bone or pelvis. Over here you can see the ligaments are in place. It's rough and irregularly shaped, so when it moves, minimally it's okay, but if it moves too much, those surfaces aren't supposed to do that, and that hurts. And so what we think happens in a fair number of people that come in with lower back pain problems is through minor trauma or for reasons we don't understand, these ligaments become incompetent, and the joint, instead of having a little motion, becomes fairly mobile and hurts a lot. Next one. So again, this just highlights that anatomy. The ligaments hold the joint still. There's a tiny bit of motion there, and when that gets excessive, it can cause pain, because this is a big, big joint, has a lot of nerve supply. Where does it hurt? Okay, this is where it really gets fun, because this joint mimics just about everything else I've been telling you about in the lower back. It can cause back pain, hip pain, leg pain, pinched nerve symptoms, groin pain in some people. I had one lady that had female area pain on that side. Some men will complain of testicular pain. Again, those are not common, but they occur. Most commonly, you feel it right over here where that dimple is. But if you come in sometimes and you have these pinched nerve sciatica-like symptoms, you have a clean MRI, this is often what's going on in the background. The tricky part is when you don't have a clean MRI, you have a big bulging or protruding disc or bone spurs there, like we looked at, on the same side, and you have these symptoms that act like a pinched nerve. You know, that's why it takes a lot of steps sometimes and a lot of careful judgment to determine it's not just a dropkick kind of conclusion that the MRI is positive, that's what's wrong. That's what it looks like. That may not be what's wrong. So next one. So this was something that before the herniated disc was figured out in the early 1930s, this was recognized as a big problem with, as far as being the cause of lower back pain. And once the herniated disc became recognized with modern imaging, the sacroiliac joint kind of fell out of people's focus, and everyone just forgot about, like, okay, it doesn't exist, here's herniated discs and bone spurs and whatnot. We now know that, you know, this is still an issue for people, and there's become some increased emphasis on that, because we know that some of the cases where we're not helping people that we think are in their backs are really not from their spines, it's from this. But because of this part and because of the prominence of these issues, a lot of training programs don't train people to look for it. They just don't even think to look for it. It's not evaluated. We don't really work it up and evaluate with our tests. And one of the lucky things in my case, where I trained, we did a lot of scoliosis. And when you do those big long fusions in people as children, when they come in their 30s, that levers through that joint for years, and that joint becomes uncomfortable. And where I trained in Minneapolis, we had a lot of folks come in their early 20s, 30s, whatever, that had that. So we were very familiar, my bosses were very familiar with it, and I was lucky enough to be trained in that. But if you're not trained in it, or if your mentors don't recognize this, a lot of folks out there will not pick up on it. It's not that they're not smarter, they're this or that, or it's that hard to do. It's just that if you don't have this in your repertoire, you're not going to think of it. A lot of the modern studies show 20–25% of low back pain that we don't understand, or garden variety low back pain, is not coming from your spine. It's coming from this. And it mimics these other things, so we often get wrapped around the axle of the herniated disc, or the spinal stenosis is not what's happening. So that does lead to potential for misdiagnosis, surgeries that don't always help, because maybe we corrected one thing, but we didn't get the right thing, or we corrected one thing but there's still something else here. Next picture. And the big thing with why that's difficult is because it mimics other things, but because the pictures of the SI joint when it's hurting are usually normal. Okay, bone scans, x-rays, MRIs, CAT scans, you name it. The overwhelming majority of cases, they don't look odd or abnormal, they look okay. So the thing we rely on to back up our assessment doesn't help us. MRI is not proven to be positive. CT scans frequently, no help. Next one. So we rely, like I said earlier, the history. We try and get the history out of you that will help us sort this out versus what else could it be. There are a number of physical exam findings that put stress across the joint in various different directions, that if a sufficient number of these are positive will help confirm that diagnosis. So we rely heavily on that. Next one. And then if we have a suspicion with the history and the physical really adding up and the pictures don't show anything in the spine that otherwise explains it, we try to have you go to the pain clinic and get the joint injected and have them numb it. And really, I try to have them numb it and put some other, cortisone, other medicine in there to help it, because we want to make this go away, the most conservative way possible. But the main value of this, even if it doesn't help it, is that while it's numb, it can help confirm or disprove this as the source. If you block that joint with a lot of local anesthetic and it gets really satisfyingly better for a few hours, that correlates with how long that local anesthetic works, that tends to confirm that that's where it's coming from. And if you can repeat that a couple of times and you get consistent results, then that tends to really clinch the diagnosis when all those other factors are true. Well, that's good, thank you. So we treat this conservatively just like everything else. And you realize after you watch a few of these slides, like, you don't have to be that smart to practice medicine. Everybody gets the same thing every time. Why does it take 20 years to do this? You're right, it's just not, that's not the whole thing. But yeah, we use the same conservative treatments that help in other areas. Anti-inflammatories, therapies, strapping or belts across the pelvis that hold that joint in a more stable configuration sometimes give people relief. Steroid injections, chiropractic. You can do little radio frequency procedures where you put a probe in and deaden the nerve endings to it. And sometimes that, if you take those nerve endings out of commission, you can reduce the amount of pain for up to a couple of years. A lot of different techniques. But these don't always work, or they don't always work sufficiently for everybody. So in those cases, you can fuse the joint, just like in the spine. And there are many ways to do it. The older ways that were popularized in the early part of the 20th century were really big gargantuan operations where you have to make a big incision and expose that area and scratch out bone, and just like in the other fusions like I've taught you, put in bone chips, right, and add hardware. And the bone chips grow together and the hardware helps it. It's a big incision. We have some newer technology now that's minimally invasive, that's real nice, and the real thing here is this is not an end-all, this is not a cure for everybody. But if you confirm that diagnosis and that's truly the main source of their pain, there are some newer fusion procedures where you can put these implants or similar things across the joint. They stabilize it immediately, and they have a porous coating, like a spongy surface made out of titanium that bone likes, and it grows into it and grows across the joint over a number of months and permanently stabilizes it. So this is nice. You don't have to add the bone. It kind of drags its own bone in with it. It takes about an hour to do it. You don't have this big incision on your back. You go home the next day, and in folks that are selected well, different studies show 80 to 90% satisfaction. But the key thing here, as always, is we have to be treating the right thing. We have to be sure of the diagnosis, and that's the hardest part of our jobs in the spine, is figuring out what is it versus what isn't, what is it not. So newer treatment for SI joint stabilization. So take-home points there briefly, just to wrap it up. It's underdiagnosed. If you're having trouble that doesn't make sense and they can't figure it out, it may be part of what's going on in your case in the lower back. You have to have somebody that understands how to do this, examine the SI joint. I have some of my physical therapy folks trained in this. My nurse practitioners trained in this. I know how to do it. And we have to spend the time and do some of those exam findings. We can't always do them all in the middle of a busy office, but we try to take the time and get folks situated and look at that. And if that's the case, you try conservative treatment, get the symptoms under control, and if that doesn't work, we can sometimes do a surgical procedure to help that. Okay. And that's all I've got.